Welcome to this video on mastering PTCE drug interactions. We will provide a comprehensive guide to Section 1.3, Common and Life-Threatening Contraindications, covering key topics for exam preparation and patient safety. Be aware of common exam traps, like relying on common drug pairs without checking for absolute contraindications and overlooking dietary supplements. Use shortcuts like memorizing critical interactions and employing elimination when absolute contraindications are present. This 4-week study plan focuses on different drug interaction types each week, including high-alert drug-drug interactions, drug-disease, and drug-nutrient interactions. Remember to complete your daily flashcards and practice questions, and review your timed quizzes. We examine critical warfarin and DOAC interactions. Combining warfarin with NSAID or ASA increases major bleed risk. Warfarin with CYP2C9 inhibitors, like TMP-SMX, spikes the INR. For DOAC and PGP inhibitors, a dose adjustment may be mandatory. Critical statin interactions include simvastatin with clarithromycin, which increases rhabdomyolysis risk via the CYP3A4 pathway. Gemfibrozil doubles the statin AUC through a non-CYP pathway, making any combination contraindicated. Combining MAOIs, like phenelzine, with SSRI, SNRI, or meperidine, presents a serotonin syndrome risk. Symptoms include hyperthermia and agitation. Reversible MAOIs, like linezolid, require avoiding concurrent use with drugs like dextromethorphan. Cumulative QT prolongation risk from drugs like ondansetron and fluoroquinolone can lead to torsades de pointe. Technicians must flag 3 QT prolonging drugs for prescriber review. Always assess cumulative risk. The benzodiazepine plus opioid combination has a boxed warning due to the risk of severe respiratory depression. Newer traps include gabapentinoids added to opioids, which also increase respiratory depression risk. Always counsel patients on associated warnings. St. John's wort induces CYP3A4, reducing the levels of drugs like oral contraceptives and digoxin. Counsel patients on backup contraception. The interaction manifests 1 to 2 weeks after starting the supplement. Tetracycline chelates with polyvalent cations found in dairy products and antacids, reducing its absorption. The dosing separation rule requires 2 hours before or 4 hours after tetracycline administration. Pregnancy in children 12 years and under are contraindications. The MAOI-tyramine interaction is a life-threatening contraindication leading to a hypertensive crisis. Tyramine sources include aged cheese and cured meats. Patients must restrict tyramine for 2 weeks after MAOI discontinuation. Ginkgo and garlic inhibit aggregation, potentiating warfarin and increasing bleeding risk. Ginseng has a variable effect. For all 3, counsel patients to hold them 7 days before surgery. Non-selective beta blockers like propranolol are contraindicated in asthma/COPD as they precipitate bronchospasm. Cardioselective beta blockers like metoprolol are safer at low doses, but caution is still advised. Remember to check eye drops for systemic absorption. NSAID use inhibits COX-1, reducing protective prostaglandins and causing GI injury. Mitigation strategies include co-therapy with misoprostol or a PPI. High-risk groups include the elderly and those on corticosteroids or anticoagulants. Category X drugs, such as ACE inhibitors and warfarin, pose major risks in pregnancy. Technician duties include labeling bottles and verifying female counseling. If a patient on a Category X drug is pregnant, withhold the dose and call the prescriber immediately. Drug laboratory interactions include biotin supplements interfering with immunoassays, potentially causing false lows. Dextrose IV can dilute serum sodium, leading to pseudohyponatremia. Technicians should ask patients about supplements before blood draws. Here are 5 sample questions and rationales for common and life-threatening drug interactions. Key examples include warfarin and fluconazole, clopidogrel and omeprazole, and sildenafil with nitroglycerin, which is absolutely contraindicated due to severe hypotension. We continue with more common drug-drug interactions. For example, theophylline combined with ciprofloxacin increases theophylline levels and tremor. Methotrexate and trimethoprim increase the risk of bone marrow suppression. Case study 1 involves simvastatin and clarithromycin, which increases statin levels and risk of rhabdomyolysis. Case study 2 involves St. John's wort and oral contraceptives, reducing efficacy and increasing the risk of unintended pregnancy. The PTCE exam simulation includes a 60-minute practice block mimicking the real pace. Section 1.3 coverage is heavily weighted toward drug-drug interactions. Aim for an 80% benchmark score to proceed with certification exam scheduling. This video has covered crucial aspects of PTCE drug interactions. We focused on common and life-threatening contraindications, mechanisms, and management strategies. Remember to review the high-alert drug lists and technician actionable knowledge provided throughout this video to enhance your patient safety skills and exam readiness. Thank you for watching. We wish you the best in your PTCE preparation and success in your career as a pharmacy technician.